Thank you, Dr. Amant, for reporting on your groundbreaking research. We have come to the stage where we're going to invite questions from the floor. I would first of all like to invite all of this morning's speakers to approach the stage and take your seat on the stage. The questions and answers session will be chaired by Professor O'Dwyer. We have very limited time, so if you could please keep your questions brief and to the point, we'd very much appreciate it. And you have earned your lunch, so lunch will be served at 1:30, so we don't want to run any further than that. Thank you very much. So we'll invite our first question. Lady down at the back there.
Thank you. The question for Dr. Calhoun about the perinatal hospice. I may have missed this, but you mentioned about the psychological effects for women who've had terminations. And I just wondered, have you compared the psychological effects post-hospice compared to post-termination?
And that's a very good question, and that's one of the areas of research we need to look at, because I don't have a formal evaluation. There was a qualitative analysis done by one of my colleagues out of Marquette, looking at a subgroup of women who went through hospice, looking at narrative, and actually had very positive outcomes, but I don't have a head-to-head comparison of hospice patients compared to non-hospice patients.
Gentleman in the middle here, Rebecca.
Question to Dr. Amant. You said that the bad effect of the chemo and radio start about 2 to 4 weeks after giving it. Is that right?
The toxic effect of chemotherapy?
Yeah.
Well, the effect on the bone marrow, of the maternal bone marrow, starts actually from day 7, day 10 after giving chemotherapy. Well, in some women there's no hematologic toxicity. If it occurs, it can start after day 7, and then it depends a bit on the bone marrow reserve, how long it and how deep actually the bone marrow depression is. And if you have a severe depression, you might have an increased risk of infection, or if your platelets are too low, that might jeopardize a cesarean section or delivery. And that's why we claim for a 3-week interval. And that's why we should not give chemotherapy after 35 weeks of pregnancy, because then there's more likelihood there is spontaneous labor, and that's not manageable anymore, so after 35 weeks of pregnancy, we would wait and not give chemotherapy.
That will branch to 2 things. So what is the maximum time you can give in pregnancy, and why did you delay till 14 weeks starting? Why not starting from 11 weeks, for example?
I think that's a very good question, and I don't have the answer. This was based on a consensus meeting. We had a consensus meeting with obstetricians, neonatologists, and we said, okay, strictly you can start with 11 weeks, but the data are not so firm. Let's take a safety period. And that's actually if...
Safety as just not sure that this is through 11 weeks, or why is the safety?
No, it has not been shown. It's possible that it's safe.
So why not get a sure ultrasound and start with? Because if you're not going to get anything till after that, and the baby is fully formed at 11 weeks, why not?
I think you can do it, maybe, but we don't know. The risk is a bit higher on congenital malformations. We have to make sure, we have to know that also, for example, the reproductive system, the brain, does not stop during the organogenesis. They continue to develop afterwards. So it's not very strict, this period. So in order to not to stress a period where the organs are still developing, we prefer this period of safety. Also, from oncological point of view, for example, and this has been well demonstrated for breast cancer, waiting 2 or 3 weeks will not jeopardize your prognosis with chemotherapy. So if you take these two together, we thought the safety window might be a good choice.
Question for Dr. Chireau. You said that preeclamptic toxemia is increasing, and you cited 3 etiological factors, genetic, immunological, and environmental. I wondered, would the environmental be due to obesity, which is also increasing worldwide? And I wondered, could you make a comment also on your experience of obesity effect on C-section and incidence of diabetes?
Yes, certainly. It's always startling to me when I travel to Europe how much thinner people are here. It's really pretty amazing. I have patients that I operate on who have a BMI of 45, 47, which is a significant problem. I think the worldwide increase in preeclampsia is due to 2 factors. One is the increasing incidence of hypertension. We're seeing more hypertension earlier in children in the United States. We're seeing type 2 diabetes in children as young as 7 to 8 years old. And there's a correlation between diabetes and the development of preeclampsia during pregnancy, and also a correlation between obesity and preeclampsia, having to do with probably an inflammatory etiology. And inflammation does seem to be a part of the pathogenesis of preeclampsia. So I think that that is one reason why we are seeing more. The other reason why I think we are seeing more preeclampsia is that many women are choosing to have children older in life when they begin to be in chronic disease territory. So for the prima gravida who's in her late 30s and early 40s, who may have a family history, who may be becoming more and more obese as time goes along and begins to develop chronic hypertension or diabetes, there's an age-related risk as well. So it's being seen on both ends, both due to delayed childbearing, but also due to us seeing more obesity, more hypertension, and more diabetes at younger and younger ages. And your comment about cesarean section was having to do with obesity and cesarean section? Right. So there is a clear correlation between not just obesity and the risk for C-section, but for postoperative risk in cesarean, postoperative risks in patients who are obese who have cesarean section. There's also a risk risk for dystocia and labor abnormalities in patients who are obese as well. And anyone who's had to deliver a woman who is extremely heavy can understand the difficulty of doing delivery when the patient's limbs are very fat, when the abdomen is very fat. And so this presents some significant challenges. We've tried to overcome some of those challenges. Again, I live in practice in the southeastern United States, which is called the stroke belt, with good reason. As I said, I've not operated on someone with a BMI above 50, but my colleagues have operated on people with a body mass index of 54. And I think that, yes, Byron's nodding his head. The surgical issues can be considerable. We still are hopeful, we'll try for vaginal delivery. In the massively obese patient, there are some surgical maneuvers that you can take, such as trying to tape the pannus up, trying to not operate in the crease. There's a lot of debate about whether paniculectomy, removal of the abdominal pannus during cesarean section, actually helps. I have not found that to be helpful. In fact, I found it to be kind of disastrous. What?
Bloody mess.
Yeah, it's bloody. It tends to get infected. And in my experience in Native American populations, in this population of women, 50% of whom are diabetic in pregnancy, usually somewhat obese, the other problem that you run into is that their wounds break down and then they get infected with MRSA, and you really have methicillin-resistant Staph aureus, and that's an issue. We've tried wound vacs, the vacuum-assisted devices to try to promote wound healing, and so far I just haven't seen a great solution to that problem, but it's an ongoing issue. Did I answer your question?
This is a question for Dr. Amant. It's me over here. Thank you very much for the fantastic talk. This is probably a premature question, but it'll make us think. What might happen to the gonads, to the testicles and the ovaries of the children in utero when their moms are having therapy, cancer therapy? Because these children will grow up and have children of their own. So I know this probably will take another while to find out, but I thought I'd just raise the question. Thanks again.
Well, from our own series, the children, but I acknowledge that the group is still young. We did not see any delay in puberty or any developmental problems of the secondary reproductive organs. We know from other studies that there is no increase in worse outcome of these children, and also that these children, actually, there is one small study that shows that children from the children actually also have a normal outcome. So the chemotherapy, the radiotherapy does not seem to be any impact on mutations that may impact actually fertility or lead to subsequent malformations. But I acknowledge that the evidence is suboptimal, and we hope by prolonging our study to have better data on that.
We're keeping Professor Amant very busy today. I also have a question for him. You mentioned near the beginning of your talk a patient with stage 1B1 carcinoma of the cervix who was treated with amputation of the anterior lip of the cervix. Now, I just wondered if you could expand on that a little bit. I mean, given that there's about a 5% chance of lymph node nets in stage 1B cancer, how do you reconcile that?
Okay, I think we decreased this. Okay, your figure is fine, 5%. However, we decreased, or we made sure that we were safe by, well, let's say it differently. There are, from the trachelectomy studies, there are 5 studies that looked into relation of lymph node positivity and parameteral invasion for cervical cancer. And from these studies, and they confirm each other, that if your patient has negative lymph nodes, if you resect the nodes and histologically they are negative, if your tumor is smaller than 2 centimeters, and if there is no lymphatic space infiltration, then your chance of parameteral involvement is less than 1%. So, and we took these characteristics in order to justify actually the procedure. So actually you mentioned the 5%, but we start with proving that the patient is lymph node negative. And only after that, actually, we wanted to be conservative and to maintain the pregnancy. So the most important risk factor, actually, we deal with it. We make sure that she's low risk and that lymph nodes are negative. You see, you started from, in O1B1, you have a 5% chance of lymph nodes which are involved, which is true. But that's why we start with doing lymphadenectomy, to make sure that she's low risk. And then we look into other tumor characteristics that show that there is no parameteral invasion. And if that is the case, then we do believe that you do not have to do a trachelectomy, because this is done also during pregnancy. We now believe that this is too invasive and that the obstetrical outcome and the neonatal outcome are actually too bad. So in these patients, we prefer an amputation of the cervix rather than a trachelectomy. And this is actually the same procedure as is done in young women who are not pregnant, but where this strategy is executed in order to maintain their fertility. And we believe that what is safe for these women might be safe for pregnant women as well.
Yeah, but that treatment might be considered for a patient with 1A, 1A1 or 1A2. But 1B cancer, we don't have enough data yet to say that surely is a safe procedure, maybe for the child, but for the mother in the long run.
Well, we believe that at least in our center, that we have long treated these women too aggressively. I'm not sure that you should do a wartime hysterectomy for a stage 1A2. If we have now these new data on the trachelectomy cases, actually we now say for long years we have been too aggressive. We can be less aggressive. And for stage 1A1, the standard treatment is a conization. So even for these cases, there is no exception. So.
Yeah, I would agree. So I'm saying that
okay, sorry.
You're treating these patients as for a stage 1A.
Yeah.
But this patient had a stage 1B, and that does certainly increase the risk of local regional recurrence.
Yeah. But these data are actually very recent. It's in one year ago, I think it was, all the data are summarized, and now we get more data on all these trachelectomy series. They've been defending these trachelectomy studies for years, and now actually we got larger series where we can look into the prognostic data, and where we can look into tumor characteristics and the risk for parametrial invasion. And I think until recently we did not have these data, so I'm quite confident that there might be a change in the clinical attitude there.
Okay, I think I'm monopolizing the discussion. I'll pass on. Thank you.
Any further questions?
Mary Houlihan in the Rotunda. I would like to thank Dr. Calhoun for his exposition of care of the woman who has a lethal diagnosis for her baby in utero. But I would just like to point out that this is the care that's being given to women in Ireland in all of the units that provide this level of diagnosis, and that we just don't put the fancy title on it, and that it is the care that women get, and that the continuance of pregnancy in women who have a lethal diagnosis for their fetus in utero in Ireland is actually incredibly high. Thank you.
Lady up at the front.
Question for Dr. Calhoun. I just wonder if you could comment on your experience with parents who, following the baby's survival over the first few days, discharged to the care of the parents at home. How many of them change their own wishes with regard to the care of the baby and then seek more active management, such as respiratory support during intermittent deteriorations, and sometimes there's stepwise deterioration? How many then move from this palliative approach into seeking a more active approach, as we're certainly hearing many stories from the USA where parents with infants with lethal abnormalities are being supported to have very active intervention, including home ventilation. So I just would like your comment on that.
That's a very good question. I really don't have the data on that at this time. That's probably an area we're going to have to look at again, because that has changed a lot. When parents would go home, money that would just do hospice care. The ones I had for my patients were doing hospice, and so the older data, they were not doing as aggressive. Most of them would just be home care, oxygen, and that sort of thing. But that's a good question that I don't really have data for at this point. I'm sorry.
Okay, the gentleman down at the back, or lady down there.
Sorry, Dr. Calhoun, I would like to ask you a question too. Here in Ireland, and encephaly is one of our biggest problems with lethal congenital abnormalities. Every year in Ireland, 20 are born, which I think is scandalous, because it can be so easily prevented with folic acid. So it's not quite your question, but I wonder, have you seen any decrease in encephalic babies in your care since folic acid was put into flour in America?
That's a very good question, and actually the best data I've seen recently is that's true, that there's been a decrease between, I think, 10 and 25%, depending which places you look at and which you examine, because of the folate added to both flour and all processed products, as well as the awareness of most of my obstetricians now that treat almost all their women preconceptually. Actually, anybody who's sexually active and wants to have children, almost all are getting folate supplementations, and anybody who's had a baby with anencephaly or neural tube is getting 4 milligrams of folic acid. So that's clearly something that's decreased our incidence of all, not just anencephalies, but neural tube defects in general, frankly.
Any further questions? I think that concludes our questions and answers session. We're breaking for lunch now, and I invite you to return at 2:30 p.m. I'd like to thank our morning speakers, and there are many more speakers to follow. Thank you very much.